Today we're going to be looking at personality disorder, and on the next slide we're going to be looking at some of the objectives associated with this lecture. So we're going to identify characteristics of personality disorder, differentiate between different types of personality disorders, and then look behind these disorders to see the emotional and clinical needs not only of the nurse but other staff when caring for individuals with personality disorder. We're going to identify psychological needs based on Maslow's hierarchy, looking at nursing diagnosis and also interventions on behalf of personality disorder. In order to move forward, we need to understand what personality is. And personality involves those consistent attitudes, beliefs, desires, and values that really make us who we are. And they're unique to each individual. It's about how we think, it's how we perceive, what are our experiences in life. And then we take all of these things that make us who we are and we see that they're ingrained in us. Whether it be how, again, based on how we think, how we're feeling, but also how we're behaving. With personality disorder, though, the traits are more inflexible and they're maladaptive. So we've gone from things that make us who we are, that are ingrained in us, that are adaptive, which means we're flexible, we're easy for change. But when it becomes maladaptive and inflexible, then it becomes more of a disorder. And it's more of a disorder because these individuals are impaired socially. It affects their occupational functioning. And this is not just through in their dollhouse. This happens throughout, from the very beginning of childhood all the way up into their adult life, because that's how our personalities develop. That ability to have trust, autonomy, independence, and meaningful relationships within these individuals are going to be limited. There's also, again, these traits that really hinder them from not only developing these relationships, but also feeling fulfilled and having those feelings as if they can enjoy their life. With Maslow's hierarchy, there's the theory, well, that's just much a theory, is to understand that people tend to respond in a characteristic way to stress in their lives. Most individuals are adaptive with it, so they're flexible, or they're maladaptive and they're very rigid. And this determines really the difference between whether or not it is healthy or unhealthy. An unhealthy person responds to stress by really being narrow ranged in their behavior and psychopathology. When it comes to psychological health, with Maslow's hierarchy, we're first looking at safety. Then we're going to look at love, affection and belonging, self-esteem, recognition and achievement, self-actualization, and understanding how that within these individuals with personality disorder, that their mental illness demonstrates that there were needs that weren't met in at least one of these four categories. So with anxiety disorder, a lot of energy is needed to meet this person's need to have love, affection, and belonging. Their need is really insatiable when it comes to personality disorder for that recognition and esteem. So you have your anxiety disorder and their needs are just not being met. With personality disorder, they need to be recognized and they need to have self-esteem, and this desire is overwhelming for them. When their needs are not met, then these individuals become withdrawn, isolated, and can identify as being a loner. They'll go to extreme lengths to protect themselves. They don't do well socially with establishing rapport, and so they have an intense mistrust. Now, if we go back to Erikson, where Erikson talks about when there's a development stage of trust versus mistrust, that's usually a child. And that's when we develop our personalities. And therefore, you can see this as something that's progressing throughout their childhood. So when we're dealing with these individuals, because they lean more towards a mistrust, we have to be cautious about how we touch them, how we approach them, about their routine, and how to enhance their sense of safety. When there's an unmet need for love, affection, and belonging, then there's a high dependency on other individuals. They can be whiny, indecisive and compulsive. They can be clingy to their caregivers to the point of being emotionally and physically draining. There's a lower level need that needs to be met first with that safety. With clients' dependency, they feel as though their needs have to be met first above all else. And there are ways in which we can engage the patient to accomplish tasks while helping them to be realistic about their goals. It's very tricky to be able to do, but it can be done. With unmet need for recognition, self-esteem, and achievement, these individuals are highly self-centered. They have difficulty with long-term relationships. They can become frustrated, impulsive, emotional, and it can become volatile. They're routinely manipulating other individuals. And so, more commonly than not, these individuals have a tendency to have at one time or another been incarcerated to serve time. Their dependency is really based on behavior that they use to try to gain some type of power. With unmet need for recognition, there's this power becomes intense. And if this need is not met, then they begin to become threatened and they act out in behaviors. It's important, though, as nurses, that we all, as caregivers, adhere to a treatment plan or to teach family and parents to make sure that they stick to a treatment plan. There has to be limitations that need to be set without an exception, and that the decision making should be limited to responsibilities at first. So limit decision making responsibilities at first, but then as they begin to improve their behavior, then you can add on to that responsibility. Identify the predominant needs. Understand that the client's behavior, what that behavior is, and then plan for appropriate care. Remember, the goal is to help them develop better patterns to manage the everyday activities of their life. So with safety, nursing diagnosis with individuals with personality disorder include impaired social interaction. So the goal is that we want the client to be able to express feeling comfortable in an environment by a certain period of time. And most of the time that's by discharge if they're inpatient. With love and affection and belonging, some nursing diagnoses that we're going to see are anxiety. So what are our goals? Our goal is that the client will identify anxiety-provoking situations and plan for them. That's teaching them how to cope. With self-esteem, recognition, and achievement, the nursing diagnosis could be a high risk for violence. And the goal can be that the client will learn how to control their behavior and engage in problem-solving techniques. Personality disorder comes in several clusters. One is cluster A, where their behavior is odd and eccentric. So you'll see diagnoses such as being paranoid, schizoid, or schizotypal. With nursing diagnosis, it includes anxiety, ineffective coping, social isolation, and disturbed thought process. And you'll see some of these repeat throughout as we go forward. With your cluster B, they're dramatic, emotional, erratic. You can see them being defined as histrionic, narcissistic, antisocial, and borderline. Nursing diagnosis that you're going to see, ineffective coping, but we're adding to that now chronic low self-esteem. They can have risk of self-mutilation, because their behavior is erratic, also risk for suicide and risk for violence towards self or others. And then in your cluster C, you have them being anxious and fearful, so they may be have avoidance behavior. They could be dependent. They could have obsessive compulsive or passive aggressive. And other nursing diagnoses we're going to see, similar to what we saw in cluster B, is anxiety. Across cluster B and C is ineffective coping. Across B and C, we have your self-esteem, and then you have your impaired social isolation. And if I'm not mistaken, that's in cluster A as well. Personality disorder characteristics, again, go back to the patient being inflexible and having maladaptive responses. They have difficulty working and loving, difficulty evoking interpersonal conflicts, and they have the capacity to be able to get under the skins of other people. So just remember that, again, individuals who have personality disorder can also have a substance use abuse that go hand in hand with it. Personality disorder has also been overly diagnosed in clients when it comes to ethnical and cultural differences. With drug therapy, there's usually nothing that can be effective. There's a few things that come up like anxiety and things like that we might be able to treat. But for the personality disorder, that's really a learned behavior. And so that's going to take some cognitive behavioral therapy. Markers, biological markers, and biogenetic predisposition has always been studied and said that individuals can be predisposed with personality disorder. And the research continues with looking in to see about the predisposition of this disease process. Antisocial personality disorder is diagnosed based on a history and psychological testing to determine that individual's ability to be manipulative, to ignore social rules about their dishonesty, lack of remorse, and criminal activity. It affects more men than women. A large portion are in distress due to crime, violence, and social aspects. And when it comes to society, when it comes to personality disorders and who it decides it's going to affect, there is no limitation. There's no biases based on age or race or even class. It can affect anyone. It can affect businessmen, scientists, physicians, politicians. And when it comes to rule following, you will find that these individuals have been breaking the rule since they were 15 years of age. Other psychodynamic issues include fixed disturbance of development. So we talked about Freud with the id and the super id and the ego, and within this there's the conflict between the super ego and the conscious that tells them what they're supposed to do. When it comes to personality defenses, their defense mechanisms are designed to gratify any impulses that they have. Other family influences could be having an unplanned or unwanted pregnancy, having been abandoned by one parent, exposed to violent temper, physical and sexual abuse, and the fact that some have reported not having really good moral values and behaviors. Social and environmental issues include economic deprivation, family criminality, poor parenting skills, school failure, hyperactivity, impulsivity, and attention deficit. With antisocial personality disorder, it's detected in early adolescence between the ages of 18 to 24, that there's usually some emotional immaturity and impulsive need for gratification, so they don't have that resilience, and guiltiness. There are some biological influences. We're not going to go into that in detail, but we talk about it throughout that there's the proof that there is some predisposition based on some studies that were done with twins. So when we're assessing a patient who has antisocial personality disorder, when it comes to their affect, they're going to be very charming, self-confident. They make really good friends. They don't have much anxiety, depression, but they do project anxiety on through attacking other sensitive areas or other individuals. So there's a guilt factor that comes along with that. So there's feeling of remorse that can soon be forgotten, and they go from denial into rationalization. There's some shallowness where it is defined as that individual's feelings or emotions being superficial and really just for the person who's listening. As we continue on in our assessment, these individuals are unable to love, cherish, or care about other people. They have are drained of their emotional energy, and they're not really drained of their emotional energy. I'll correct that. It's more or less of they have no energy for anyone else because they rather spend their energy focusing on themselves, and they no longer um, ha- um, have concerns for people. Like it's not necessary, and they're very hurtful and deceitful to those people who they are around. Some behavioral patterns that we might see is pathological lying, cheating, um, using sex as a tool, physical and verbal aggression, lack of responsibility, extremely talented or intelligence, but chooses not to take any responsibilities for their actions. When you're planning goals, we want to make them move towards changing their behavior. Remember, it's going to be slow. Nursing diagnoses include high risk for violence directed towards others and ineffective individual coping. So, when it comes to the nurse's feelings and reactions, patients are going to be charming and intelligent. But there's also going to be frustration and anger as patients resist wanting assistance. And there's, with this disorder, comes along hopelessness along with some anger. Problematic behavior of antisocial personality disorders include the seducer, the passive aggressive. They like to keep the ball in the air, keep things like that little bit of contention there, and have that help me if you can kind of space. With nursing care, the expectation is that the patient is going to participate in treatment programs, sign a contract, understand the consequences of their actions, and then understand that there are set limits that are going to be enforced. So there's going to be rules, and they have to play by them during the time that they're receiving help. With your borderline personality disorder, they can be very troublemakers, very good troublemakers, problem patients, more so female than it is males. And if it's a male, they're most likely in jail. When we're assessing them, we're going to see hostile and demanding behavior, staff splitting, manipulating, criticism, suicidal threats, and the list just goes on and on. Other nursing diagnoses that we're going to see that pertains to borderline personality disorder include the risk for suicide and self-mutilation, the risk for violence and ineffective coping along with isolation. And then you have your long-term psychotherapy with some in-hospital stabilization. Other interventions for borderline personality outside of possible inpatient treatments include setting goals for them and using clear actions. Be mindful of ways in which they can be manipulative. Use clear and consistent boundaries and limits. Use clear communication. When they start to show problem behaviors that might show up, make sure to set goals and boundaries. And then assess for suicidal, self-mutilating behavior, especially when it's during their stressful period. Paranoid personality disorder, that individual is suspicious and has mistrust, they're rigid in their thinking, they're guarded, their reality is distorted, they like to blame others, and they have a restricted affect. Nursing diagnoses include impaired social reaction, ineffective individual coping. So how do we intervene? Avoid being too nice, clear explanations of what is expected of them, including on tasks. Use simple, clear language, provide a neutral but kind effect, and explain any changes of medications that they may have. Medications play a limited role in relieving their anxiety, mood swings, and impulsive aggressions. For your cluster A, though, they might be on antipsychotics. With cluster B, it might be mood stabilizers and atypical antipsychotics for bipolar. And then for your cluster C, more you'll see your SSRIs.